Sarah, tell us when to start. Sarah, tell us when to start. Okay, Dr. Kamlesh, I think we are live. Sarah, can we start again?
Yes, sir.
Yeah. Dr. Kamlesha, unmute yourself.
Okay.
Sarah, tell us when to start. Okay, Dr. Kamlesh, I think we are live. Sarah, can we start again?
Yes, sir.
Okay. Good morning, friends and colleagues. I welcome you all to a very innovative webinar on palliative care. As you are aware, the vaccination drive is in full swing, and many of the senior citizens, as well as most of the healthcare workers, have already been vaccinated. However, as there is a surge in new cases of COVID-19 and demand of hospital beds has risen, I urge all the fellow doctors to motivate everyone to get vaccinated. At present, this seems to be the only way out of this pandemic. We at Bombay Seaboard Medical Association are known for arranging interesting CME webinars on wide range of subjects. We have a very interesting CME today on palliative care with esteemed speakers. It will throw a different light and understanding on this aspect of healthcare. Our speakers are Mrs. Firoza Bilimoria, Dr. Suniti Khanna, and Dr. Rajam Iyer. I am thankful to Dr. Jawar Mehta and Dr. Anil Mehta, Jawar Mukhtar, sorry, and Dr. Anil Mehta for organizing this webinar. As usual, we are very fortunate to be joined by Bombay Medical Union, Sir H.N. Reliance Foundation Hospital, GPA, FFAPI, the Bombay A Ward and D Ward Medical Associations, and Jain Doctor Federations. I will now ask Dr. Jawar Mehta to take over Jawar Mukhtar to take over the proceedings. Jawar.
Yeah. Thank you, Dr. Kamlesha. I hope I'm audible.
Yeah.
It is said that palliative care has been the best kept secret in healthcare. I think probably because today there are still far too many people that are unable to access this essential service. And that's the reason why it's called the best kept secret. We cannot achieve universal health coverage without palliative care, which is a key component to the right to health and the United Nations Sustainable Development Goal for good health and well-being. In 2014, the World Health Assembly passed a resolution titled Strengthening of Palliative Care as a Component of Comprehensive Care Throughout the Life Course. This resolution, for the first time, called on all nations to strengthen palliative care against the course of all life-threatening diseases. To quote Dr. Tedros Adhanom Ghebreyesus, the present Director General of the World Health Organization, the COVID-19 pandemic has highlighted the importance of palliative care in all healthcare systems. The need for relief from severe suffering, the difficult decision-making, and complicated grief brought on by the pandemic are exactly the types of problems that palliative care was designed to help address. The world will be a better place when palliative care is available to all who need it. The number of lives lost globally to the coronavirus are a harsh reminder of the need to ensure that the end of life is a priority for all healthcare providers. Palliative care, including access to pain treatment, is recognized now as a human right. The continuum of universal health coverage includes promotion, prevention, treatment, rehabilitation, and palliative care. Every country's healthcare system is now gearing up to include this robust palliative care service, as without it, healthcare will not be universal. The majority of those needing healthcare remain those with non-malignant conditions. Whilst traditionally associated with the care of people with cancer, palliative care should be available to all those who need it, regardless of the diagnosis, especially children and older people. The need for palliative care has never been greater and is increasing at a rapid pace due to aging of the world's population, increases in cancer and other non-communicable diseases, and the recent emergence of COVID-19. By 2060, the need for palliative care at the end of life is expected to double. Keeping these goals in mind, I think we need to educate ourselves on how to go about it, and that's one of the reasons for this CME to take place. Finally, to quote Theodore Roosevelt, who said, "People don't care what you know until they know you care." So let us start knowing how to care. With that, I will start with today's presentations. I'll ask Dr. Bharat Bhatt to come forward and to introduce Mrs. Firoza Bilimoria, our first speaker. Dr. Bhatt, unmute yourself. Dr. Bilimoria, unmute. You need to unmute.
Yeah. Good morning, everybody. On behalf of GPA, I extend my warm wishes and welcome to you all. And it is my privilege to introduce such a colossal personality, that is Mrs. Firoza Bilimoria, who is a founder trustee of an NGO which runs by the name of Palliative Care. Now, prior to her stint with this NGO, she had 33 years in media and marketing communications, where she ran a media group with interest in magazine publishing, trade shows, conferences, and cable distribution. She was highly regarded in media and advertising circles. Right from her early 90s, she had many prestigious industrial positions. She was elected the first woman president of the Advertising Club, Bombay, the first woman chairperson of the Advertising Standards Council of India, the first woman president of the Indian Chamber of International Advertising Association, which is a global body having its headquarters in New York, and the first Indian to be elected honorary secretary at the world body of the same organization. And incidentally, she received the IAA Championship Award in glittering ceremony in London in 2013. But ever since, I think that is 2015, she lost her husband in 2013, Mr. Jimmy Bilimoria, due to CA lung. And so that is why in 2015, that is in December, she established a NGO in commemoration of memory of her husband, the Jimmy S. Bilimoria Foundation. And she is a founder trustee of that foundation, which is there since 2015. Now, Jawahar said enough for Palliative Care, but just to touch upon her, this Palliative Care base, she has a home-based palliative care in the city of Mumbai to those who are suffering from life-limiting and debilitating conditions, primarily cancer patients across the length and breadth of the city of Mumbai. And the best part is that they are comforting the patients at their home. So ideally, I think they meet with the more, I mean, just in the computer, they use, the user friendly. Here, they make it patient friendly, according to me. And it's just not comfort the patient, but even the relatives are comforted, the family. And then ultimately, it is the society at large which enjoys this comfort. And she has a team, multidisciplinary team of 5 people, comprising of 1 doctor, assisted by 2 nurses and 1 psychological, and above all, full-time employees. During the last 5 years, Palliative Care has looked after close to as many as 1,500 patients and their family. So ultimately, it has impacted almost 6,000 or more people. And always, I mean, it adds every new month 30 more patients. So currently, at a point of time, it is approximately covering 120 patients. So I think with such a illustrious career, and I mean classical, sorry, I'm not trying to be casteist or religious. She's a typical Parsi philanthropist, and I think the city of Mumbai is fortunate to have a lady like her. And may I now invite our Mrs. Firoza Bilimoria. You know, when I introduced, when I was talking to a foreigner friend of mine, he says from the biodata, her surname should be changed from Bilimoria to Billionairea. So I said, I have not seen her balance sheet, but I know her worksheet is worth the billions. So may I now welcome Mrs. Firoza Bilimoria.
Thank you, Dr. Bhatt, for that very, very flattering and complimentary introduction, and for all that you've said about palliative care, PAL care. You, Dr. Jawahar Mukhtar, you too. It's heartening to know that you have understood so much about what palliative care is and made it a point to understand. It's something which is very dear to all of us who are in palliative care, to our hearts, because we feel passionate about it. Not enough is known about it, but a lot more is known now than when I started out in 2015. I'm going to start my presentation, and forgive me for 1 second. Let me get to it. Oof, wrong. So can everyone see? I can't, yeah. Are all of you able to see the screen?
Yes, we are.
Okay, thank you. I'm going to start with talking about my own life experience, because I think it's important that people in the audience understand what triggered this whole thing off in me, and what I think most of us go through when we lose a loved one. And hopefully with palliative care coming into much more prominence now, they won't have to suffer the way some of us had. As Dr. Bhatt told you, I lost my husband to CA of the lung in the year 2013. But you know what was amazing was that in 2010, December, he started with a cough. The cough continued into January, and antibiotics didn't seem to be curing it. And surprisingly, 4 months before that, he'd had a full medical checkup because he had to get his insurance renewed, and they wanted to do a medical checkup. And he came out with flying colors. His lungs were pristine clear. And Jimmy was always a health freak. He would play golf. He would run around the race course twice every evening. He was very particular about the food. He used to drive me crazy about how much oil to use and not to use. And he was really very health conscious. I was the one who was, not so blasé. I was more blasé about my health. But it's, cancer doesn't decide who, it doesn't matter how healthy it comes. And I think in Jimmy's case, maybe it was genetic, because most of his relatives have all had cancer. When we first discovered it, which was in January of 2011, we were told that he didn't have more than 6 months. And but no one mentioned the word palliative, because nobody knew about palliative then, I think, or very few did. My sister, who lives in Delhi, she had been diagnosed with a thymoma, which is a very rare cancer in the chest. It's the thymic gland which catches the cancer. And of course, they couldn't handle it here. So she had gone to London to Dr. Peter Harper, who runs a very well-run cancer clinic, London Oncology Center. And so we consulted him when Jimmy got cancer, because Olive was still under the treatment. And he said, I'm a lung specialist. Actually, that is my specialty. So we decided to go there. And that 6 months, I have to say thanks to Dr. Harper, became 2 years. We didn't stay all that 2 years in London. We came back to India after the first treatment started. And we were in touch with him, and we had an oncologist in India, and things were pretty good. Considering we were told 6 months, Jimmy was still going back to his board meetings. He was a director on several boards. He just retired as chairman of Siba Gaigi, and now was on several boards. He was going to his board meetings. He was continuing to play golf in a buggy, didn't always be able to walk the full round. And if you saw him, on the street or at a party, you wouldn't even know that he had cancer. And the treatment was working. From, his lung, when it was first discovered, had at least 50 lesions in it, more than that probably. And it had spread to the lymph nodes, it had spread to the pleural cavity. And at the end of that first round of this treatment that Dr. Harper had done, and Jimmy was one of the first patients to also have genetic sequencing, and they had found a drug which wouldn't normally be given in lung cancer, but it was given in colon cancer, but seemed to be working on him. And 2 years later, in December of 2012, it had spread to his brain. In January 2012, our oncologist said, there's nothing more we can do, just go home and take care of him as best as you can. There was no one to tell me what to do. I struggled and I made lots of mistakes. I was sleep deprived, I was depressed, and anything wrong that I could have done, I did. I wasn't told how to give the morphine. It said give it every 4 hours, give it every 6 hours. Nobody told me that it has to be given at a certain time and must stick to those timings, that there are things like rescue doses that you just don't increase, go to 20 mg once because the pain is more, than go back to 10 mg. Anyway, I didn't really have anyone to help me except my own common sense, which wasn't working too well in those days. Jimmy had made me promise that he didn't want to die with tubes in his body. He didn't want to die in a hospital, and I made that promise. But not having anyone to help me, I panicked when there was an emergency, called an ambulance, and we rushed to Breach Candy Hospital, which is it's 2 minutes away from my house. And he was put into the ICU, where he stayed for 10 days and died the most awful, awful death. Up to today, even every time I think of those 10, 12 days, I get cold shivers and I can't sleep at night. Especially around the anniversary of that time, it torments me. It torments me that we put him through what we did. And it depressed me after he died. But sometime in October of that year, 2013, I was called to London for this championship award, which Dr. Bhatt talked about. And when I went then, there are 19 nations who are a part of the International Advertising Association. And I'd been involved with it for a long time, so I have many friends there. And each one came up to condole and, talk about Jimmy, etc. And practically 90% of them said, oh, why didn't you resort to palliative care? And I said, what is that? Never heard of it. That was the first time that I'd even heard the word palliative. And what they took as granted, we didn't even know of. So because I was very upset about having broken my promise to Jimmy and allowed him to die with his hands tied to his bed and these tubes all over him, especially one tube which was in his mouth, so he couldn't even talk because they were secreting his lungs all the time. I was keen to find out more about palliative care because I said, if others cannot suffer like I did, like Jimmy did, why not see what it is? And so a cousin of mine in the UK, in London, introduced me to the ex-CEO of a very well-known palliative care outfit in the UK called Marie Curie. And this ex-CEO who was working at Imperial College at that time, he'd retired from Marie Curie, and they were working on palliative care policies and principles. He looked up, Googled, and he said, what are you saying? Of course, there's palliative care in India. He talked about Tata Memorial has a department. He talked about palliative care in Kerala. He talked about cancer support in Delhi. He says, you didn't have access to it, but it is there. In any case, since it's so scarce in Mumbai, why don't you go back and start small and let it grow. And I'm there to help you and encourage you. And whenever you need any advice, I'm there. So I came back to Bombay and I met up with Ratan Tata because Jimmy had been a director on many of the Tata firms. And I met up with Anand Mahendra and a couple of people because I needed to be sure that I had enough funding to start something. I also met up with Dr. Marianne Mukherjee of Tata Memorial. I met up with Harmala Gupta of Cancer Support. And Cancer Support looks after 2,000 patients at a time. They're so big now. They've been there for 30 years in Delhi. Started small like me and grew to this size. And again, they do home care. And they both said, why don't you go to Singapore? There is Dr. Akhileshwaran there, and he runs a very well-run establishment called HCA Singapore, and we've all learned at his hands. So I went to Singapore. I learned from him what was to be done and what. And these three people helped me set it all up. And of course, as I said, I got the funding also set up. So that was my journey, and that's how I entered the world of palliative care and set up PalCare. I think Dr. Bhatt has already told you all this about PalCare. This presentation is not about PalCare, but about palliative care. And I only want to emphasize is two things. One is the role of the caregiver. We very often forget that the caregiver, be it a family member or be it a paid professional like a nurse or a nursing aide, is very vital in what we do. Because we go there and we set the care plan, and then we keep looking at that care plan and tweaking it and making sure that the patient is comfortable at all times. But the caregiver has to be empowered, and to be empowered has to be educated in how to deliver that care plan so that what you have decided can be carried out. And we've seen that when we have caregivers or families who are dysfunctional, the patient suffers. And those are the times when sometimes we have to say to them, please move to Shanti Vedna, you can't manage at home. But our goal is that 90% of our patients should die at home. At the moment, we're at 81% of our patients die at home. Some have to die in hospital, some 10%, I think, and the other 10% die in Shanti Vedna or a hospice. There are more hospices turning up now. But the role of a caregiver is very important, and we have to understand that we have to give respect to the caregiver. We also have to understand that, patients must be given respect and autonomy to make the decision. So we advise them what we feel is right. But if they want to do alternate therapies, if they don't want to follow our advice, we don't reprimand them for it, or we don't stop treating them. We try and convince them. The other very important part in palliative care, whether it's for cancer or any other condition, is the role that the psychologist plays, because it's when you get the patient into a state of mental and emotional and spiritual well-being, then the physical well-being happens much faster. I've got some examples later, but I did want to highlight those 2 points. I also wanted to highlight that because palliative care is a new concept and it's growing in India, we have to be learning all the time. And therefore, it was very important for me to have, and because I'm not a doctor, I'm just a layperson, I am surrounded by, so I have to make sure that I have the right team of doctors and nurses. And by right team, I don't mean just medically or education-wise, but I mean by way of also understanding and appreciating and buying into the concept of palliative care. But I also needed experts. So I set up a clinical advisory committee, and I got some stalwarts onto it. And then we meet once a month. Now it's become once in 2 months. And they give us advice. So we take up cases and we say, this is what happened. And they will tell us what we did right, what we did wrong. And it's a constant learning process, because I keep saying to my team, if we're not going to do it well, let's not do it. But it's very important that we're providing the kind of relief that we've set out to do. This is not just something that, it's a job and therefore we can say and I can say, oh, at society circles, I'm into NGO activities. That's not the idea. The idea is to actually make a difference. I also had a very high-powered board of trustees, Deepak Parekh, Ishat Hussain, Rustam Mehta, etc., because I knew I needed the credibility. I was not a doctor, this was a new NGO. So I set that up also for them to help us get onto the right governance track so that we were doing things correctly, because we're not here for 1, 2, 3 years. We're here hopefully well beyond my grandchildren's lifetime. And that's what I hope will happen with PalCare. So as Dr. Mukhtar said, what is palliative care? And it is the best kept secret of our times. It's a little known third arm of medicine. And unfortunately, very little it's not been given the right kind of importance that it should have. Fortunately, when I see myself now, 5 years later, when I say I'm in palliative care, I don't get raised eyebrows of people saying, what is that? Now people at least have heard of palliative care. They may not actually be practicing it, but even doctors in those days, you say, what is that? Why are you doing that? And then they would scoff. We don't need you, we can manage, etc. But we're not saying, in fact, we're hoping that all doctors will learn palliative care and bring it into the practice in some way or the other, because it has to start at an early stage. And at an early stage, it can only happen when you, as doctors and general practitioners, bring it into your practice. The World Health Organization defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And I think that well-being is the word that we need to concentrate on. It is well-being. Health is also spiritual health. We all know that, modern medicine came around after the Industrial Revolution. But by the 1950s, the advancement of science and medicine provided many more treatment options, and therefore people opted to die in hospital, which is not where people should die. They should die at home, surrounded by their loved ones. And if you ask patients, 90% will say, I want to die. I don't want to die in a clinical environment with cold walls around me or, in a ward with other dying patients. I want to die in my own home, in my own bed, surrounded by my loved ones. Also, the medical profession, even up till now, death meant failure rather than a natural end of living. And it's very difficult for all of us, even me, after all these years. We still fear the word death, and we must not. We must be able to make those conversations early in life, early in the trajectory of a person's condition, illness, because that makes such a difference. I have to tell you another personal story, and, I'm giving you these examples only because it exemplifies what I went through and what I believe would have helped if there had been palliative care. My father, when he was 8, he had a minor stroke. He was moved into Breach Candy Hospital, again, because we live close by, and because there wasn't any bed anywhere else, they put him into the ICU. Within 7 days, he had a huge hemorrhage. If he wasn't in the ICU, he would have died there and then. But because he was in the ICU, they were able to keep him alive. After 7 days, of course, and he had to go onto the ventilator immediately. Nobody knew in those days that you could, say, do not ventilate, etc. And my mother, of course, wasn't willing to even think of that. 7 days later, they did the tracheotomy, and he lay in that ICU for 6 full months, and 3 months after, in the first room outside the ICU, stuck to that ventilator. If somebody had told us then that, look, this is what the consequences are, or we could be, maybe we would have thought differently. Maybe we could have convinced my mother. My sisters and I certainly didn't want him to die this way. And when he did regain consciousness, which was 3 months later, full 3 months, he was totally dead to the world. He couldn't move the slightest finger. But his eyes were moving. He was conscious. He could understand. And very often I would walk into the room because I was still doing my full-time job, but I would spend my days at the hospital, nights I would work at home, etc. I'd often see a tear running down his face. This is not how he wanted to die. This is not how we wanted to see him die. But nobody talked about it. Nobody said, look, this is not, this is what, it's your choice, but this is what could possibly happen. And maybe we would, I don't want to blame, the blame is on us also. But I'm saying, therefore, early conversations would have made a difference. 7 days only, because by 7 days we had to decide, but we didn't even talk about it in those 7 days. So I think, these are the things that we need to bear in mind. So palliative care really came in the modern day palliative care that we know of today, when Dame Cicely Saunders, a nurse, set up the St. Christopher's Hospice in London. She, like me, lost a loved one to cancer, and that's what triggered her off wanting to start a palliative care center. She wasn't a doctor like me, but she was a nurse. So she hired a friend of hers, Dr. Mary Baines, who was the main doctor who looked after St. Christopher's, and She passed away only last year at I don't know what age, 90 or something, past her 80, mid 80s. St. Christopher's Hospice is identified as the start of the modern hospice movement. And that is because, not that it was the very first hospice, but because it was the first to combine science with care and sharing of experiences. It took a holistic approach, caring for a patient's physical, spiritual, and psychological and social well-being. So that's what made it stand out. It wasn't just a place where you go to die. It was a place which offered a combination of science with caring. This was a new beginning, not just for the care of the dying, but for the practice of medicine as a whole. And that's why palliative care in the UK has advanced to levels that, we still have so far to catch up with. At the same time, another woman, and tomorrow is World Women's Day, so it's not surprising that we're talking about two women here. Elizabeth Kubler-Ross, she was a Swiss-American psychiatrist. And this whole thing about not wanting to talk about dying and death was something that Kubler-Ross addressed way back in 1969 with her book, which was a best-selling multi-copy book, where she advocated the Kubler-Ross model. And she said that experiencing grief is something that we go through in 5 different emotions. First, we have denial. Then we have anger. Why me? Why did this have to happen? Then we have bargaining. Maybe if I do this, maybe if I promise God I'll be a good person, maybe if, I give this kind of medication, or I give this kind of food. Then when it doesn't work, there's depression. And finally, there's acceptance. So why palliative care? As I told you, you saw what happened to me when someone you love or, falls seriously ill. It affects every part of their body, of their being, as also those who are a part of their lives. I can't tell you how traumatic the emotional pain can be. It brings up all kinds of different emotions, not only in the patient, but those around, the guilt feelings, things that one could have done, not done, etc. Palliative care doesn't either try to hasten or postpone death, but it tries to address all these different aspects by providing comfort, whether it's physical comfort or emotional comfort, whether it's spiritual comfort, and by trying to bring symptoms under control. Because the main aim is that the patient should have some quality of life, even while we know the patient is not going to live beyond a certain period of time. That we know that this is a life-limiting condition. But that doesn't mean that that life-limiting condition has to be lived in misery. When I look back, I think it was good that Jimmy was able to spend time playing golf, go to his meetings, etc. Yes, the last 3 months were not good, but in a sense, I think Dr. Harper already had palliative care in his curative care clinic, because he had what he called a wellness clinic. And they had a psychiatrist there, they had somebody to help you with, if you lost your hair, what kind of wigs to wear so that you had your own social dignity. So loss of social dignity is a big thing in especially cancer patients. But the whole idea is that you must be able to live in dignity and be respected as a human being, not just a number in a hospital bed or on a doctor's list. You are a human being first, and you must be respected for being that. Pain and suffering, I'm not going to go too much into this in detail, but except to say that there is visible pain and there is invisible pain. And in the visible pain is obviously the physical pain that we can all see. But what is not often visible and is often therefore forgotten and not treated is the psychological and emotional pain. The social pain, like I said to you, we didn't get invited to someone's 25th wedding anniversary. And Jimmy kept saying to me, I don't think they want cancer patients there. I said, don't be silly. Why would they not? They forgot us. But it's not because you have cancer. But that is the kind of thing that cancer patients will think. There is, or any patient with a life-limiting disease. Also because, with chemotherapy, there is body odor. There sometimes is, if you have a cough, you're constantly coughing and it's embarrassing. If you have a huge, big lesion on your, in your mouth or your face, then it's often sort of fungating and it's all smelly, and sometimes you even have maggots in it. So there is social pain. You don't want to be seen like that. And very often my husband would say, please don't call anyone over. I don't want to be seen like this. So, and there is also spiritual pain. Why has this happened to me? Did I do something wrong? Is God punishing me? So unless you address all these issues, the physical pain sometimes can't be kept under control. And it's very important, therefore, even as doctors, that you should address some of these issues if you don't have a psychologist as an adjunct to your practice. Ideally, you should be able to put them in touch with the counselor and say, let them handle this, because it's very important in that whole care. I think there are some myths about palliative care, and those need to be broken. First of all, myth number one is that palliative care is not just for cancer. It's equally applicable to all chronic illnesses. Non-communicable diseases are in fact on the rise, but they're not often perceived as being life-limiting. You think of cancer, you say, oh, she's going to die, because 80% of patients with cancer, at least in this country, die. But with non-cancer patients, the course is very unpredictable. With cancer, you know that, now it'll happen like this, then this will happen, then they will go into this kind of situation, there will be extreme distress, there might be hallucinations, there might be all this sort of stuff. But with non-cancer patients, some of the course is very unpredictable. They suddenly get well, think everything's all right. The next time that you meet them, they're again back to, being worse off than they were when they came and saw you. And because of this longevity of the conditions, there's a high burden on patient and caregiver, which may not happen in cancer. And I remember after my husband died, after 2 good quarter years, one of the doctors said to me, see, you can go to the fanciest oncologists in the world, but lung cancer lasts 2.25 years, and that's the trend we've seen. So with cancer, it's more predictable. With non-cancer, it's not so predictable. And there's a longer longevity of the illness, a longer trajectory, and therefore can be also much more taxing on both patient and caregiver. And, what is it? What is that matters? If you're falling off a high-rise building, a skyscraper, while you're falling, you want someone to be able to talk to you so that the way you land becomes important. You can land on your feet and maybe not broken into small smithering pieces, but you are going to die, yes, but the way you die is going to be different if you have that support system. I'm again going back, and I hope I'm not running out of time, but I delivered my first baby in London, and 2 days after I came back from the hospital, the doorbell rang and I went to it, and there was this lady at the door. She said, hello, I'm a social worker and I have to come and help you look after the baby. And I said, no, I don't need you. My mother's come from India. I'm okay, thank you very much. She said, no, it's my job. That's what the National Health pays me for. I have to come. And she was with me for 3 months, and she was wonderful. I mean, I don't know what I would have done without her, because she taught me things which my mother couldn't have. There was, more scientific thinking about it also. But it made a big difference to me. And I was so relieved that she had been there. When my husband was in his last stages of life, I kept saying, oh, I wish that woman was, I wish I could have a woman like her around. And therefore, it's so important that we have, because she talked to me, she told me what could happen, what could not happen with a baby, why you do things, why you don't do things. I needed someone to do that with me, with this cancer patient. Tell me what are the what are the possibilities and what are the options on how to handle those possibilities if they do arise. No, they just all came as being blasted, out of the blue. So another myth is that palliative care is only for end of life. That is not true. In fact, more and more, there is evidence to show that it can help prolong life, because if you have a better quality of life, you're going to be able to, not years, but some more months, maybe years. We have patients who've been with us from year 1, now maybe year 2. So we've got patients who've been with us for 3 and 4 years, though 50% of our patients die in the first month. But most often, treating physicians will only resort to palliative care when all curative options are exhausted. Sorry. And that's why we need to break this myth. We have to start earlier. It doesn't necessarily only have to be coming to a specialized palliative care center. It is that you can do it also in your daily practice. This diagram shows that you have screening, then you have curative diagnosis, then you have curative care. And if you start palliative care side by side, there'll be little palliative care in the beginning, but as the patient's condition goes down, there's much more palliative care towards the end. Then, of course, there's end of life and bereavement. But what it also means is that, when the patient now comes to us, very often they come to us, oh, I'm going to die. That shouldn't be what it is. It should be that this palliative care goes hand in hand with the curative treatment, so it doesn't become a shock system when it does have to come to end of life. And as I said earlier, in our case, and I'm sure this is the case everywhere, 47% of our patients died in the first 1 month. Another nearly 20% in the second month, in 2 months. So you can see how late cancer patients come to us. When they come earlier to us, then look, they can live 9 to 12 months with us, 18 to, we've got someone who's living with us for 48 months, who's been with us under our care for 48 months because they came earlier, we were able to get control the condition. Maybe the cancer was also not as aggressive, but it is important to start looking at it early. It's important to have the conversations early. It's also important to have the treatment early, the palliative care treatment. Myth number 3 is that it's just not providing succor. So often people say, oh, like Mother Teresa, you're running an organization like Mother Teresa. Mother Teresa did a fantastic job, fantastic. But she wasn't running a palliative care center. What we are doing is we're providing scientifically designed treatment options. And PalCare, the clinical committee that I told you at the advisory board that we put together, spent 2 years researching 39 different symptoms which are very common in palliative care. And we produce this palliative care guideline book. And this becomes like a handbook for everyone, doctors and nurses and counselors, to keep referring to when they're meeting their patients. So I'm very happy to share that link with you because you can look at it, it's bullet-wise and it's been very, very well researched. Where can you get palliative care? I think all of you know this. But respite homes are now becoming slightly more prominent, or should become also, because a hospice is one thing. A respite home is sometimes what happens with our patients when they're not doing too well. And we find that the family can't cope. If we could send them away for 10 days to a respite center who can bring that particular condition into focus and under control and then come back home, it makes a big difference. You know what we're hoping? We're hoping that eventually palliative care will be found with every family physician, that all of you will learn the basics of palliative care and you will not just learn it, but you will apply it in your practice. We're hoping that every major hospital will have a palliative care wing, just like Kokila Ben has, like Hinduja has, like Tata Memorial, of course. But it has to be a part of all kinds of conditions, and therefore all kinds of doctors must build it into their practice, and every major hospital should have a wing for palliative care. And we're hoping that every oncologist will be a proponent of the discipline so that they will start sending patients earlier to palliative care than they do today. In Mumbai, there are several places, not enough to take care of this huge population, but that's a list here. There are hospices, respite centers, individuals, like 2 of them, Raja Mayar, who you're going to listen to next, or later on, hospitals, as I mentioned, Prince Ali Khan also. And then there are non-profits like my organization, Romela Palliative Care, On Care, Just Cap. And what makes me feel very good is when I started in 2015, apart from some of the hospitals, I was the only non-profit. And now I see it mushrooming, and I feel good that I was able to start that movement where more and more people felt, courageous enough to start their own palliative care centers. I'm going to leave you with two wonderful quotes because I think they are very important and they're something that I carry around with me all the time. And they're both from Dame Cicely Saunders. And she said, "You matter because you are you. You matter to the last moment of your life. We will do all we can do, not only to help you die peacefully, but to live until you die." And just think of those words, how poignant they are. You matter because you are you. You matter to the last moment of your life. You're not just a patient number. And you matter. We will do all we can do, not only to help you die peacefully, which we want you to die peacefully, but to live until you die. And then the other quote, which I carry around a lot, is how people die remains in the memory of those who live on. And that's what happens to me. I mean, those memories still haunt me. Anyway, thank you.
Thank you, Mrs. Bilimoria. That was a wonderful presentation. I think you learned a lot and sensitized us a lot to palliative care. We will go on to the question answer session in the end, and we'll take up a few questions then. I will now I'll ask Dr. Vibhakar Adhwariu to introduce Dr. Smriti Khanna for the next session. Dr. Adhwariu, unmute yourself. You can stop sharing the slides.
Yeah. Good morning, everybody. I have the proud privilege of introducing Dr. Smriti Khanna, and Dr. Smriti Khanna would pardon me for editing her biodata, which was so long, or else I would have taken much of her time in introducing her. Dr. Smriti Khanna is a consultant at Romila Palliative Care, Bandra. She's a consultant palliative and supportive care unit by Jarbai Wadia Hospital for Children in Parel. She is a member of End of Life Care Committee by Jarbai Wadia Hospital for Children. She is secretary of Jivan Sparsh Foundation, and she is a member of Mumbai Palliative Care Network. After doing her MBBS and MD in general medicine in India, she achieved her MRCP in the UK in the year 2016 from Royal College of Physicians, London. She has her super specialty training in hemato-oncology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She has 2 years experience in adult and pediatric clinical hematology, including benign and malignant hematology and bone marrow transplant. She has her palliative care training in basic certificate course in palliative medicine at Institute of Palliative Medicine, Kozhikode. She has ongoing International Children's Palliative Care Network's e-learning program, and she is in ongoing MSc Palliative Medicine, Cardiff University, UK. She has held various positions after her postgraduate training, some of them amongst which are Chief MICU intensivist at Karuna Multi-Specialist Hospital, Mumbai, Associate Consultant at Total Kidney Care Clinic, Mumbai, Associate Consultant at 9 private and charitable dialysis unit in Mumbai. She is Senior Resident at Department of Hematology and Bone Marrow Transplant Unit at Sanjay Gandhi Postgraduate Institute, Lucknow. She has received various awards and achievements. She has had many research and presentations to her credit. She has organized various workshops and training programs. May I invite Dr. Smriti Khanna to address us.
Thank you, Dr. Arun, for that wonderful introduction. It's indeed a pleasure to be a part of this program, and I'm quite happy to note, and I'm quite inspired that so many of you out there, so many family physicians, are looking forward to learn more about palliative care. And if I may, I'd like to share a little bit of my experiences, share a little bit about how, as a family physician, a patient who is at the end of life, how they can be managed. Are my slides visible?
Yes.
Lovely. So today we're going to talk about end-of-life care from a family physician's perspective and the role of a family physician. So this is what I want to discuss in today's lecture, that what does end of life mean in a patient, in anybody who is suffering from a life-limiting illness, and what can a family physician do with a patient like this? How can they help a patient like this? So some ideas about what a family physician can do are, we can help identify active dying, or what active dying means here is that we can help identify when death is near. We can help identify when a patient may have a few days, a few weeks, or a few months of life left. And we're going to be talking a little bit more about this. What symptoms are going to be present at end of life? What symptoms should we expect, and how can we control them? And Firoza spoke a lot about a good death, especially with that quote by Dame Cicely Saunders about how a person dies lives in the memory of those who stay behind, and how we can help achieve a good death. So that ensures dignity of death for the patient, and that ensures that the memories that the family members have after the patient's death are not unpleasant. And even after a patient, even while a patient is being taken care of, and after a patient's death, the caregiver is the one who remains behind and the one who also needs our support and care. So we've spoken a lot about dignity in death, but when we talk about figures, let's see where we stand. In 2015, Lancet, the journal, issued a report on the quality of death index, where it compared the overall scores of different countries all over the world. This diagram is actually a little too small for you to be able to see the details, but I can tell you that UK and Australia come right at the top, UK, Australia, New Zealand, and way down below comes India. The dignity of death report, the quality of death report, measured scores of 80 countries. And so now we know that India ranks amongst the 15 worst countries to die in. When we talk about end-of-life care and what it means, it's an approach to a terminally ill patient, and it shifts the focus of care to symptom control, to comfort, to dignity, to improving the quality of life and improving the quality of dying, rather than any treatment that aims at cure or prolongation of life. So it's not about adding days to life, but it's about adding life to days. Now, one thing that I think because of modern medicine, we have a habit of forgetting is that death is actually a natural event. It is a natural culmination of life, and it is a natural process of life. And end-of-life care, it recognizes this fact, it acknowledges this fact, and therefore it includes physical, social, emotional, and spiritual support. And this support is provided to everybody who's going to be impacted by this event. So for the patient and for their families. And our goal here is to control pain and to control other symptoms so that the patient is as comfortable as possible. It is end-of-life care is just good medical care. It's good and comprehensive care. Palliative care or end-of-life care does not mean that we hasten death. It does not mean that we prolong the dying process. So we are not looking to play God here. We are not looking to fasten up things here. We are not looking to prolong things here. In this list, you will find some patients that end up in the ICU. You may have seen this, or you may have noticed this maybe in your own family, maybe amongst your patients, that people with end-stage organ failure, people with degenerative conditions, a lot of these form the bulk of our ICU patients. And these are the patients who have been chronically ill, who have had ups and downs in their illness, whose families have been taking care of them for 5, 10, 15, 20 odd years. And it's not just cancer or malignancy that comes in this. There is every organ failure possible comes into this list. So cardiac, renal, liver, lung, neurodegenerative conditions. Even individuals who are at advanced stage, elderly, frail, may not be having any particular chronic condition that's very serious. These end up in the ICU. But many a times when we hear stories about what happened in the ICU when they went, how their families were not able to stay in touch with them, to be with them, and how they died in the ICU away from their family, away from their home, we stop and think that should they have been in the ICU at the first place? Now, how do we make that decision? How do we decide for them? How do we help them decide for themselves? It is not our place to decide for them, but we need to help them decide for themselves. This last point, that is patients with an advanced directive expressing no aggressive treatment, is also a part of those patients that end up in the ICU, because we don't have much in the form of written directives to that. All we have is somebody telling their loved one that they would not like to get into the ICU. But we are going to focus on this last population patient area in our next lecture. So, as I said, how do we decide which patients need to go into the ICU and which patients it's time to take a step back and reflect and have a family discussion, talk to the relatives? There is a surprise question that is often asked in the UK in palliative care circles. And the question is that, will you be surprised if this patient is not alive in the next year? If the answer is no, then it is time for proactive palliative care. Then it is time for regrouping, reassessing, talking with the family, saying that, okay, let's take a step back and think this patient of yours, this loved one has gone through many episodes of hospitalization, has gone through many deteriorations. It's likely that the next time they end up in the ICU or they end up in the hospital, that may be their last admission. That may be the end of their life. And how do you think they would like to have the end of their life? How do you think we should go? We should do this. So if you are asking, what can I do in all this as a family physician, then here is my reply. This is actually taken from a position statement, which is a joint position statement by the IAPC and the Academy of Family Physicians in India, that how can a family physician incorporate palliative care in their own practice, and what are the advantages of that? So a family physician has accessibility in the community. They already have a pre-existing rapport and trust. And trust is very important, especially when it comes to end of life decision, when it comes to patient preferences, when it comes to discussing what is to be done next in a situation. I'm sure you must all have faced this situation when patients are admitted in the ICU in the hospital and they call you up sometimes at night, at any times of the day, saying that the doctor is telling that my father should go into the ICU. What should I do? The patients come back to you for answers to questions that even they are having a tough time trying to answer. You have a knowledge of the patient, including the psychosocial, the financial status. They trust you because you work with them in the community, and you are an essential part of their journey. The family physician is an essential part of the journey. Even when even if we are talking about anything else other than offering medical advice, other than helping them through this journey of the last few years of their life. Suppose they are at home, how can we help? How can a family physician help in the end of life? We can offer basic pain management. We can offer symptom management. We can, in a sense, provide holistic care because we know the family members and we are able to offer some type of support and help to them. And we can make appropriate referrals when necessary. We can also continue with the care of the family even after the patient dies and provide bereavement care. So these are some of the steps that are important in preparing for the end of life. Where should end of life happen? Should it happen at home? Should it happen in a hospice? Should it happen in the hospital? What the caregiver needs to know, how they need to know what is the patient's condition like. They need to know what are the patient's choices. Suppose there is a situation in which the patient himself is not able to communicate, himself or herself are not able to communicate. What next to be done? The patient should know preferences at the end of life. They should, if we are able to talk to them at a point where they are coherent, where they are able to make decisions for themselves, that would be much better. The family and sometimes even the patient wants to know what will happen to them at the end of life. And this is something that they are entitled to, the knowledge. We can offer emotional and spiritual support. We can offer medical help whenever needed, and we can help with post-death verification or certification. I think this is something Firoza talked about a lot, a good death, a peaceful death, and a death in which our patient does not suffer. But this is the reality. This is the clinical reality that we come across, that we are asked questions like, how long does he have? Can you tell me, doctor, how much time does he have? And this is not an easy job. In fact, most of the times we are, if we make a prediction, we are rendered incorrect. So prognostication is not easy for us. It's not easy for us to look at someone and say that, okay, they have these many months left, or okay, they have these many years left. And therefore we sort of hide behind statements like, we are not gods. No one can say, we will talk about it later. We try to brush it under the carpet. But I think what patients and their families are looking for is just a sense of an approximation, that if we are able to judge at that time and say that we think that there are a few months left, we think that there are a few days left, especially in the last days of life, sometimes we come to know that only a few more days and the patient will be no more. That sort of prognostication, if we can offer, that sort of information, if we can offer, along with the caveat that, nobody really knows in this, but I think that it is such and such, we can help them. So these are some common symptoms that are prevalent at the end of life: pain, delirium, breathlessness, problems with skin, problems with nutrition, and secretions. And these are some symptoms that I will be talking about in the next 10 minutes. Some more signs that we may notice in the patient that is indicative that they are entering the terminal phase. And by terminal phase, I mean the last few days of life. Severe weight loss, profound weakness, no interest in food and drink, difficulty in swallowing medication. The amount of medication that the patient takes drastically reduces, delirium that is not responsive to medications, altered breathing patterns, and the patient being drowsy for a long period of time. Reduced urine output is a very good indicator that that the patient is entering the terminal phase. Skin that is cool to touch. These are some indicators. Let's talk about pain a little bit. Not all our patients will be able to express pain at the end of life, because some of them may be delirious, some of them may be unconscious. Therefore, we need to look at some non-verbal cues in order to find out, in order to for us to think of pain even. So noisy breathing, frightened facial expression, like an expression on the face that indicates hurt or fright, tense body language, negative vocalization. By that I mean that the patient isn't saying anything at all. Now, I'm not saying that all these or any or all of these can be indicative of only pain, but I'm saying that if we look at these, we should think that, okay, maybe this patient is in pain. And another golden rule is if they were in pain before they have become nonverbal or delirious, then it's likely that they're still going to be in pain after they've become delirious or unconscious. So what are some common solutions that we can do in a home environment or in a small nursing home environment? If oral routes are not available, what can we do? We can give transdermal medications such as transdermal fentanyl. We can give suppositories such as diclofenac suppositories. We can convert to subcutaneous routes of administering medication, and I will be talking about this a little later. It's important to not discontinue painkillers and opioids because, as I said, if they have been in pain before they stop talking, they are likely to still continuing being in pain. With opioids, with morphine, this is a very important thought that comes in our minds, and this is something that frightens us also. And these are questions that even patients' relatives ask us. Will painkillers damage his kidney? Will him being on morphine mean that he's going to get addicted to it? It frightens them a lot, and it frightens them more than the problems that they are having, that the problems that they are seeing their patient is having. In palliative care, we speak of a doctrine of double effect. So the doctrine of double effect says that actions that have a double effect, both good and bad, are permissible under certain conditions. That the act performed is not itself evil, and the good effect does not come out from the evil effect. It is only the good effect that we are keeping in mind when we are doing this, and there is a proportionate reason for causing the harm. So basically what it's trying to say is that we are looking at the cost-benefit ratio of this. If a patient is on opioids, or if a patient is on NSAIDs for a longer period of time, we're looking at the cost-benefit ratio. How long is that patient expected to live? Is he expected to live so long that his kidneys will fail with the prolonged NSAID use? If a patient is on morphine and he becomes sedated, the side effect of morphine is sedation, but the good effect, or the effect that we're looking at, is relief of pain. So how do we reach a sort of middle ground where pain relief also happens and where sedation is kept to the point that it is acceptable to the patient, acceptable to the family? These are some medications, some other medications that we use in pain, in palliative care, not just in end of life, but in pain relief in general. I'm not going to go a lot in detail at dosages and frequencies because we are the guidelines that Firoza spoke about before this have given all this in great detail, and not just for pain but for all symptoms also. So from pain, we now move to dyspnea. In dyspnea, what all are we looking at? We're looking at a medical approach, like a curative approach. What all, not really a curative here, but what is a correctable cause? So if pleurocentesis can happen in the hospital, then we try and work towards doing that. But we work towards doing it in a way that the patient just goes in to the hospital for the pleurocentesis and comes back home, and we don't look at all the other issues that the patient is happening, because we are looking just to keep them comfortable and not to solve every electrolyte issue or infection issue that will require a prolonged stay in hospital. We're looking at a rehabilitative approach. So breathing techniques, oxygen. We're looking at diminishing the perception of the symptoms. So this is why oral morphine helps a lot in dyspnea, and it has been proven by many studies that low dose oral morphine at a dose that is smaller than the dose given for pain and lesser frequency than the dose given for pain is very effective at dyspnea relief. We just spoke about masking the distress of the symptom, giving the patient a kind of comfort, and palliative sedation is something that is the next next step that we look at. So palliative sedation is something that is usually done after a full discussion with the patient and the family, and consulting a specialist, palliative care specialist, when it needs to be done. So at home, what we can help provide for this patient? There can be oral, there can be intranasal oxygen with a concentrator or with a cylinder. We can put the patient on oral morphine. Clonazepam also helps diminishing the anxiety or the panic that breathlessness brings along with it. And some non-pharmacological measures like using a table fan, keeping the windows open, not overcrowding around the patient too much, wearing loose clothing, sometimes non-invasive ventilation if the patient is comfortable with it. This can also help with relieving dyspnea. Delirium. Delirium sometimes is a very difficult symptom to treat at the end of life, in the last days of life. But there are both non-pharmacological and pharmacological techniques and tips that we can try. So similar with what I described with breathlessness, to provide an open space, a comfortable space, a space that the patient is familiar with. We've noticed many times that as soon as patients go into the ICU, they have delirium, and as soon as they come out of ICU, within a few days, the delirium resolves. So an ICU is a very uncomfortable, very unfamiliar environment. There is nobody that they know around them. So this is why delirium, this sort of perpetuates the delirium. So in environmental, how we can help in providing a consistent environment with the same family members or even the same caretaker if they are with the patient, keeping on staying in touch with the patient, keeping on talking to them, explaining to them that this is what is happening, reducing their anxiety by answering their questions, controlling the noise, the light around it, having a day-night balance, that there will be darkness when there is night, and then there will be light when there is day. So controlling your curtains or your lights according to that. This helps in sleep hygiene. Having the same caregiver again and again throughout the days can help the patient can help the patient feel that, okay, this is like a consistent environment around me. Now, pharmacologically, what can we do? We look if the patient is dehydrated, we try and correct that. If it is possible for us to assess that there is a kind of electrolyte imbalance, if we can add a little bit of salt to the diet, we can try and do that. Haloperidol is a very good medication that I have used for very many of my patients. And it can be used orally, it can be used sublingually, it can be used subcutaneously also. Benzodiazepines are not so much for are not as effective as haloperidol for delirium, but they can also be used along with it. Paying attention to skin and mouth care is important because bed sores can develop in as little as 12 hours. So and bed sores can be especially distressing for the parent, for the caregivers, and for the patient themselves. They can cause a lot of pain and distress. If you will remember, anytime I remember some of my family members or my caregivers talk to me about their patient, they keep talking about how they had developed a bed sore at the end of life. So this remains with them even later. So changing position, head elevation. We usually advise patients to change position every 2 hours, but in the last few days of life, I would not want a patient to go through that sort of change in position every 2 hours, because even that might be a little distressing, and we are not and we want to give as much comfort as possible. So in the last few days of life, it's okay if they change positions in 8 hours and 12 hours. Skin care by cleaning, by massaging, mouth care, maintaining good oral hygiene, hydration with just having a gauze dipped in water, or a clean handkerchief or a clean cloth dipped in water, and just dabbing all over the lips or the mucosa, the tongue. It's best to avoid commercial mouthwash if we need to make a kind of home mouthwash for them, using 1 liter water with a half a teaspoon of salt and 1 teaspoon of baking soda, and just cleaning the mouth can be very useful. Methylcellulose eye drops for eye care so that they don't develop keratitis or ulcers. Bowel and bladder care is also something that's important in the last day of life. Patients can go into incontinence, they can go into retention, either. And so it's important that we recognize it early. We use whatever is comfortable for them, whether it's diapers, whether it's like an undersheet, whether it is indwelling catheters. And constipation is actually a very common symptom at the end of life. And this, if not treated, can lead to fecal impaction. This can lead to vomiting. This can lead to pain. This can lead to severe distress. And it can lead to delirium and urinary retention. So making sure that constipation is relieved as soon as possible. This may require, whether it will require a regular laxative, whether it will require enemas or suppositories, and sometimes it may require manual evacuation for relieving of the constipation. Now, some general principles for how to give medications in patients at the end of life. Our overall principle is that we want to provide comfort care and we want to reduce pain as much as possible. And therefore, we will choose the less invasive methods. So we look at transbuccal, we look at submucosal administration. So some medications, especially morphine, haloperidol, even some benzodiazepines, can be just put under the mouth. Even if they are an oral formulation, there is submucosal take up into the bloodstream. Some medications are available as per rectal formulations, so we use that in pediatrics, especially per rectal formulations are used quite a lot, and I have used diclofenac as per rectal administration also. Subcutaneous is basically inserting what we call a butterfly or a scalp vein under the skin. There is a picture, I think somewhere here. Yes. So this is hypodermoclysis, which is the subcutaneous route for starting infusions. This can be used to give medication. This can also be used to give nutrition, to give IV fluids in a lesser invasive way, as if we compare it with IV or if we compare it with any intramuscular. Intramuscular is absolute no-no. IV is after a lot of discussion with the family. If the family feels that they would really like to give some kind of IV fluids, then we do opt for IV also. But subcutaneous is actually a very simpler and a least distressing method. There will be no extravasation, there will be no ecchymotic patches. And if we administer subcutaneous IV fluids also, having one bottle of normal saline can go easily over 8 to 12 hours. It can even go over 6 hours, but usually we give over 8 to 12 hours so that some amount of fluid goes into the patient's body. When a patient's family talks about nutrition and says that, okay, the patient is absolutely not eating, they are eating so little, and in our culture, love and care is linked closely with nutrition. And so it becomes very difficult to explain to them that this is not what is needed for your loved one at this point of time. And so some things that I say is that towards the end of life, the body starts shutting down and the need for food and drink reduces. And so if we try and feed him as much as we would feed a normal person, it would not be good for him. He may have vomiting, he may have water retention in his body. And that is why I am keen that he takes only as much as he requires or as much as he or she tolerates. There is no evidence that nutrition enhances survival in the last days of life. In fact, increased hydration can lead to consequences like breathlessness and can lead to edema. TPM is something that I absolutely do not encourage in patients at the end of life. And one other important thing is cutting down on unnecessary medications. I know that my patient is not going to last beyond a few days to weeks. So there is no sense in giving him statins. There is no sense in giving him aspirin or clopidogrel. In fact, this might cause excessive bleeding. Antihypertensives, anti-diabetic medications, these form such a bulk of the medication list that I'm okay if he or she stops taking those medications towards the end, especially supplements, especially those large tablets like calcium. And now we come to the last day of life. What happens after a patient dies? I think that I'm preaching to the choir here. This is something that you must be doing with so many of your patients, issuing death certificate, certifying, identifying death. It is very comforting to the patient's families to know that there is a family physician with them who can help them with the last day of life. And this is something that we often encourage our patients to stay in touch with their family physicians, so that these things at the last day are taken care of and they don't have to run helter-skelter while trying to deal with the grief of their loved one's death. Guiding to mortuary services, helping with grief and bereavement is something that as a palliative care team, we do. Our counselors keep in touch with them, and a family physician also can help with the same, because there are so many instances in which I find that after say a wife dies, husband stops taking medications, and then he has a spike in his blood sugar or his blood pressure, and then the family GP comes in and convinces him that he needs to continue taking his medications, and helps him, sort of restart all the medication that he needs. It's not just this, but it's a lot of other things also, because the family physician has a position of trust with the family, that he is somebody that they might go to. They might have thoughts about how the person died, and they may want to clarify that with him also. So I think I'm nearing the end of my talk. I would just like to share some reference material. I believe that we've spoken with Dr. Jawahar, and we are going to compile these together and send it across to you also. But these are some of the reference materials that you can refer. Kasturba Hospital has come up with a Blue Maple document that covers procedure and management at the end of life very comprehensively. I think that Dr. Rajan is going to talk a little bit about this. The Royal College of General Practitioners has come up with a gold standard framework, which is a very like a ready reckoner. It's a 2-page guide about how we can identify patients nearing the end of life early, and how we can provide proactive palliative care to them. And there is a joint position statement on the IAPC by the IAPC and the Academy of Family Physicians. This paper actually talks about how a primary care physician can access palliative care, can also train in palliative care, amongst other things, and how they can deliver a little bit about how they can deliver palliative care too. So to summarize, we work as a team. We work, the patient and the family are a part of the team. The oncology or the nephrologist or the cardiologist, they are also a part of the team. The primary physician is part of the team. Sometimes the palliative care physician is part of the team. Not abandoning the family towards the end. Because even just the fact that they have somebody to turn to makes everything so much better for them, and they are able to cope much better. Keeping the patient and the caregivers in the conversation about their own illness, honest and open communication, helping families prepare for death. It's something that we ourselves find it difficult to do, but when done and when done well, it is a very rewarding experience. And continuing to troubleshoot at home and care after death also. So thank you so much for this opportunity to allow me to speak to you, and over to you, Dr. Jawahar. You're on mute, Dr. Jawahar.
Sorry. Thank you, Dr. Smriti. That was an excellent presentation, giving us some good details of end-of-life care. I'm sure there are going to be a lot of questions at the end. My next task is to introduce Dr. Raja Iyer. I don't know how to begin with. I don't know how to describe such a great friend and a wonderful human being. It was about 3 years ago that we had some issue at home, and I had my father-in-law falling sick. We needed palliative care, and we approached Dr. Rajam. She guided me and my wife so beautifully, and we think we don't know where would we have been if it was not for her. So I think I should thank her publicly today. Thank you for all that you did for us, Rajam. She has a master's in respiratory medicine. Her experience includes 22 years of clinical work, both in India and international settings. There's also exposure to clinical, epidemiological, and public research. She has completed a fellowship in palliative medicine from the Institute of Palliative Medicine, Calicut. In 1992, she completed a Bachelor's of Medicine and Surgery from Bombay University, a diploma in environment, tuberculosis, and respiratory tract, followed by a Doctor of Medicine in tuberculosis and chest diseases in Bombay University, MB in respiratory medicine. She passed the Royal College of Physicians MRCP UK in 2006. 2018, completed a fellowship in palliative medicine at IPM Calicut and a diploma in palliative medicine in Cardiff University in 2020. She's a palliative care consultant at the PD Hinduja National Hospital, Mumbai, and in palliative care services in end-stage lung disease at the Bhatia Hospital. She has multiple publications. For lack of time, I will not go into that, and research papers. We are already running short, so I will now ask Dr. Rajam Iyer to begin with her presentation. Thank you.
Thank you very much, Jawahar. It has been lovely to get to know you too. And like you said, we've made some long-term friendships. So I know it was not the best setting to have met you, but I'm glad we did so that at least we have continued to maintain that relationship, and through you, able to get to much more family physicians. So what you heard this morning is a talk from Firoza about why we need palliative care much more now than ever. I think the COVID-19 pandemic has definitely brought death and dying into very sharp focus, and there's panic everywhere. And therefore, all the more need to think and talk of palliative care. Smriti also highlighted to you about the role that family physicians, the very important role of taking palliative care to people's homes. And today, what I'm going to talk to you about is the medical ethics and the medico-legal status that we have in India today, because this is something that most family physicians are worried about. Are they playing God? Are they doing the right things? And therefore, I think they find it easier to take the path of please take the patient to the hospital. So our aim is to empower you with information of when to identify the need of palliative care, how safe is it for you to protect your skin, and then go ahead to how to manage these patients. So going ahead to what I'm going to say is, I'm sure all of you love thinking of a holiday. So when you think of a trip, you think of all the details that you need to plan, where you're going to go, where you're going to stay, how you're going to go there. So every little detail is planned. Similarly, if you think of it, who is planning the last journey of your life? It's very important to think that we, like Smriti mentioned, we need to think that death is an inevitable part of life. We are unfortunately a death denying society, and therefore it is not discussed and pushed under the carpet. But if you think it is your life, it has to be your decision. Who is actually thinking? It is the person in the intensive care, or it is a doctor in a hospital who probably has never met you. But for you to make this decision, you need to plan. Like you plan your financial wills, you need to plan your life living will or an advanced medical directive. To do that, you need information. So who can give you the information? It is us doctors. You, with your robust experience of X number of years and seeing so many patients, know the trajectory of an illness, know which way this patient is going. So you have the responsibility to foresee and foretell this information to your patient. Very often, we all know that medical training in India does not focus on communication. We are not taught how to talk, and we are not taught how to talk about death and dying. We ourselves deny the fact that we should be discussing it. So now from September 2019, there is a module for undergraduates called as the 8COM module, which is attitudes, ethics, and communication skills, in the hope of producing compassionate, empathetic doctors right from the MBBS levels. So we have the information about the illness. It is therefore our responsibility to foresee and foretell and explain to the patient and the family what he or she in a journey of chronic illness may endure. Once this information is shared, it is now up to the patient and family to take up this decision. But it is our onus to start those discussions. So, very honestly, just like how we would like to take control of our lives, so would our patients. It is important, therefore, to entrust in shared decision making, to entrust in something that the person who is involved should also be a part of the decision making. Therefore, this is very, very important that that person is aware of his situation, has time to process and analyze, and then come to a decision. And very, very important to be a part of this journey for that patient of yours, along with a palliative care physician as well as the primary consultant. So if you all sit back and reflect to what would you think your illness experience to be like, none of us want to today sit and think that I would like to go to ICU. I would like all orifices to be intubated. I would like to be treated like a pincushion. So if your thought process as a doctor and a human is this, why would this be any different for our patients? We need to give them, therefore, a chance to have a choice. Very, very important for us to give them time and choice. Because if you see the way people die in this world, it can be broadly classified into sudden death. And unfortunately, if you see the percentage, less than 10% of us will die suddenly. The rest of us will go through various phases of bed-bound phase. The second graph shows typically a graph of a trajectory of a cancer patient where he enjoys a decent quality of life for a period of time. And then there is a sudden drop of poor health to his death. So this is the phase where probably cancer patients require palliative care. But today what we want to highlight is on graph C and graph D, where, like Firoza mentioned, patients with non-communicable diseases like any organ failure lead a very prolonged period of life with very high symptom burden. If you take an example, say, of a COPD patient, he's diagnosed at the age of 60 or 65 and gradually lives 10 to 15 years of worsening symptoms till his death. Every time that he meets the doctor in the hospital, it's for an acute emergency. But what happens to him between the two emergencies is what family physicians know. Is he able to walk? Is he able to eat? Is he able to go to the toilet on his own? Is he in a good frame of mind? This person is slowly becoming more and more dependent, oxygen bound, homebound, depressed, frustrated, and therefore socially isolated, and probably dies socially even before a physical death. The next is elderly. Like we all know, we are now getting into an aging population, like Jawahar mentioned. The staggering statistic is that we are going to add 300% more 60-year-olds and 700% more 80-year-olds to this country by 2050. So we are going to be a gray nation. Are we prepared to look after these people? Because almost 50% of our population is going to slowly wither away to death. What do these people at 80 and 90 need? They need supportive palliative care. So we realize here that we do have a staggering number of human beings whom we have to look after and probably be facing incurable chronic progressive conditions, which means that we really need to focus on their quality of life and not quantity. So this brings me to a case which I was closely associated with in the first week of January this year. I get a frantic phone call from a son and a daughter in the US and UK about their 80-year-old father who's fallen off trying to change a bulb. This elderly gentleman lived alone in Mumbai. He had recently lost his wife just before the lockdown and spent the entire lockdown in bereavement with his children away. And he used to be in regular touch with his children, saying he's fine. Unfortunately, on the end, 31st of December, he fell off the stool trying to change a bulb, hit his head, called his daughter and said, "I'm taking a crocin and going to sleep. Don't worry, I'm fine." The maid discovered him to be unconscious the next day. The neighbors took him to the hospital, was intubated, ventilated, and for 15 days he remained there. Now the distraught children call me saying, "Doctor, this is not how he would have wanted to be treated. What can we do?" So my question to you is, what could have been done and what can be done in the next? This is what brings us to the point of an 80-year-old gentleman. It is important for us to start having the conversations, because an 80-year-old gentleman who's lost his wife is already thinking of his own death. He's also alone. So it is a role of family physicians to start this conversation. How would you like to be treated in an emergency? Tell me what you would like to be done, especially because he's alone. Secondly, the other situation is he's already intubated and ventilated. What can doctors in the hospital do? So this is where we need to think about medical ethics. Another point not taught to us in detail in medical college. Very four important pillars are autonomy. We need to do everything in the best interest of the patient, cause him as less harm as possible. And in the situation of the COVID-19 pandemic, justice comes to highlight. We have so many patients who are acutely ill at all the same times with limited resources. How are we going to decide which patient gets the ventilator and which doesn't? That is justice. How are we to decide, and how do we triage this patient? So coming back to this elderly gentleman who's now ventilated, if he had asked him what he would have liked, he automatically wouldn't have gone to the hospital. Second thing, are we doing in the best interest by continuing him to be on the ventilator and just let him die whenever he dies? Are we not causing harm? And in the situation of the COVID-19 pandemic, are we not blocking a bed to somebody who is younger to be able to be salvaged and sent back to society? So we need to think of all this before we treat a patient who's not probably going to improve. That brings us to advanced care planning. So basically, what is advanced care planning? It is a process that basically supports any human being of good mental competence to decide how to be treated in a situation where he is not competent to decide, or to think of a situation in an emergency, how would we like to be treated. And this actually entails thinking of his values, his beliefs, his fears, and his general medical condition. So this is a discussion that can be beautifully started by any family physician at home, especially when he has a person who's known to have a chronic illness or who is known to have, say, advancing age. So this is something that you can do. And it's also a process to guide the hospital consultants. Or if you have an elderly who is living alone, it's very important, because it can simply start as a conversation between you and your patient and your family health physicians, and as well as decide who is going to be your power of attorney for healthcare. Please, if you can, help your patients record their choices, document it, or even video record and include it in their medical record. So in case the patient is alone or found, or family is traveling, at least you know what this patient has communicated. And even if the patient is taken to hospital, in the hospital, the patient is given comfort care and not aggressive life prolonging treatments. So conversations, very important to start with the patient and the family. So if you take these two gentlemen, all the United States presidents apparently have a will written, because their occupational hazard is they could be shot at any time. And they clearly write, so apparently Mr. Obama had written for denying aggressive medical treatment and to give him comfort care. If you compare it with the life of Schumacher, who every day engaged in a life-threatening occupation via his sport, apparently he never had an advance will. And what happens? A freaking ski incident ruins his life, and he's now probably poor by half his bank balance. So just the fact that it is not meant only for people who are unwell. People like you and me who are fairly healthy should also start talking about it, because you can have an acute catastrophic event that can change your life. So it's not just meant for people who are old and for people who are unwell. Do think about it, because the once you start thinking about your own mortality, it's easier to talk to your patients. So please do think for the healthy. Do talk about it for all your patients above the age of 60 with any new diagnosis. Giving you another perspective, we are talking about leaders of this world, of one from the US and one from India. Both these elderly gentlemen died, I think, in 2015 or 2013. Both these had dementia. But if you look at how they died, the senior George Bush died in his own house, surrounded by his dogs and people he loved, the way he wanted to go in his own terms. And our dear Bajpayee died in the Ames hospital by being on a ventilator after suffering dementia for 3 years. Is this how we should be treating our patients? And is this why we became doctors? So we really need to realize the point of conversations, the content of our conversation, and compassionate, unhurried conversations with our patients in order to give them a good quality life till death. Because very often we see कि ये बात तो कभी करी ही नहीं, ये सोचा भी नहीं. Everybody is hungry for honest conversations. Please remember, our patients are waiting to be asked, and very often we feel it's too early until it's too late. For patients with dementia, they lose their mental capacity. For patients who have had, say, sudden stroke, for example, the way I lost my father, I didn't have time to talk to him, but I knew he wouldn't have wanted his dignity and respect to be compromised. And he's probably the reason I am into palliative care. So we all need to think of having these honest conversations, because, like I mentioned, India is an aging population. We're soon going to have volumes of patients who are about 80 and 90, and we really need to document their preferences, because you heard the horrific stories from Italy and England about elderly care homes and COVID-19. They were just left to die, because we know on hindsight that COVID didn't do well with senior citizens. But the rage is that we should have at least asked them their choices. And that is very important, to give our patient the choice, have these difficult conversations. So this is an important day in the history, which is just coming, 2 days later from today, is the Supreme Court judgment, which was passed in 2019 after the Aruna Shanbag case. So Supreme Court has allowed the concept of living will. Supreme Court has allowed patients to give them the rights to refuse treatment and also withdraw care of an ongoing patient if it is useless, pointless, and there is established medical futility. But what Supreme Court did wrong was call it passive euthanasia. And the minute we use the word euthanasia, everybody is scared that they're killing the patient. So that is a misnomer. It should not be termed as euthanasia. It should be termed as withholding and withdrawing care. So why is it important to highlight this? Because there are certain problems associated with this judgment, which the illicit task force, which I'll just tell you in a bit, is actually dealing with. They have created a very prolonged, complicated course, and the procedure to write a living will is extremely complicated. It is not applicable to sudden ailments, like, for example, an acute catastrophic stroke. It is not applicable, and it makes it very complex that you have to sign it in front of a judicial magistrate. The justice system is not equipped to deal with all these things. So it is not all hunky-dory with the judgment, but yes, there is a light at the end of the tunnel. So it is allowing withdrawal or withholding, but they say that the hospital has to submit something to the High Court, and the High Court will make decisions. So it is time consuming. However, I can tell you that we do this all the time in the ICUs I work, both in Bhatia and Hinduja. And the two main components is communication, documentation, and involving more than two consultants of the hospital, so that there's an unbiased judgment. Once a patient like our 80-year-old gentleman is on the ventilator for 15 days, if we document with a neurologist, the intensivist, and the palliative care physician that there is no point in continuing the mechanical ventilation, we take necessary signatures from the son and the daughter, in this case, a WhatsApp video recorded because they were not in the country. Take that, the medical director signs, and we then extubate the patient, and that is called as compassionate extubation, looking after treating his symptoms aggressively so that he doesn't suffer in the last moments of his life. So both withholding and withdrawing is ethically the same and medico-legally allowed in this country. What is important is to make our doctors familiarize with this concept, for us to talk to the patients and family, to see to it that we get all the relevant signatures of the patients, stakeholders. So this is the illicit task force, which is working its way, which is a combination of three important societies of this country, which is neurology, critical care, as well as the Association of Palliative Care. And what they are doing now, they have filed an interim petition to the Supreme Court to change the terminology from passive euthanasia to withdrawing and withholding care. They have asked them to make the procedure of making living wills much simple, and we really need to engage people and community to start asking for palliative care, to start asking to write their living wills, for which we need the support of GPs. We cannot go through this without the support of GPs, because once you start talking to your patients and families, there will be awareness about this. This is beautifully written by Atul Gawande, and I think this is a book that all of you must read, which is Being Mortal. It's very, very important that few conclusions become clear when we understand that the most cruel failure is in how we treat the sick and the aged is the failure to recognize that they have priorities beyond merely being safe and living longer. It's extremely important for us to start having these conversations so that everybody's last journey, everybody's last chapter is written by themselves in full control, and we give exactly that what they want with full dignity and respect. So I'm happy to open this webinar for questions, because I know it's a very sensitive topic. It's not something which is comfortable for everybody to discuss and decide, but it has to have a beginning. We all need to start our conversations with patients who are vulnerable, like the aged and the ones with chronic illness, but also time for us, the healthy ones, to start documenting what we would like and how we would like to be treated in an emergency. Because I strongly believe in the fact that death is inevitable, but a bad death is avoidable. And it is in our hands. And I think we can all make a difference together. Thank you.
Thank you, Dr. Rajam. As always, a very lucid, very nice, crisp presentation. We'll now we can all unmute and we can throw open the floor to questions.
Madam, at either the Seaward Medical Association level or the General Practitioners Association Greater Bombay level, how can we as family physicians associate with this palliative care and satisfy ourselves in some way or the other?
So, sir, we do have an informal organization, the Mumbai Palliative Care Network, and one of its important points is advocacy. So we are actually conducting GP training, which we want to do upscale and see to it that more and more GPs get trained. And this will be done again because of the pandemic, mostly on a virtual basis. But the content of this training will include tips for you, how to talk, when to talk, what medications you can give, how you can communicate to the specialist. And I think it has to be a demand and supply like any new concept, because even the consultants in the hospitals are a big obstacle for us. There are many consultants who do not appreciate the fact of palliative care. They say, "Arey, you're giving up." So it has to have a paradigm shift in the thought process, and it will be slow. So the hope is that by the time I need palliative care, there will be people to give me palliative care. So hopefully in the next 10, 15 years is what I hope. But I think we have to start the training and the conversations now. So we will be more than happy to engage with all of you for further training, etc. So if you can tell us how you want to arrange it, we can do it. And we ideally do it on, say, in the afternoons. So we can do it on Saturday afternoons if it's convenient for the GPs, but we are more than happy to train as many GPs who are interested. Yes, Firoza.
Wanted to add that, I think it's a learning experience over time. And I think I keep telling my team that please engage with the general practitioner of the patient right from the beginning. Don't go running to them only for a death certificate. Right from the beginning, pick up the phone, talk to the general practitioner, whoever the family physician is, explain what you're planning to do, and work jointly. So if we can work jointly with general practitioners in caring for the patient, it'll become part and parcel. You will learn it much faster by just doing practical experience.
I would like to ask, what do you think is contributing to the difficulty of promoting palliative care both at the hospital and at homes? And how do we address that resistance?
Smriti, you want to go first?
I think it is a multifold thing, actually. There is resistance towards palliative care in a large hospital kind of setup. There is resistance towards palliative care in the community, and community specialists or community family physicians also. Partly it is to do with the myths that Firoza spoke about. Palliative care is for cancer, palliative care is for end of life, palliative care means we are giving up. So these are things about palliative care that have stayed in people's lives. And this is an important part of advocacy, that we try and dispel these myths, that we can have palliative care through before an illness is diagnosed, at the point of diagnosis, and any time after that. I have had patients who have come to me for pain medication even before they were diagnosed that they had multiple myeloma. And I have had patients who have come to me in the last week of their life. So that is the spectrum that we actually do cover. But opiophobia is also an important part of those. Is also an important part of the barriers that we face, because most doctors are not comfortable with opioids. Even oncologists are not comfortable with opioids.
So adding to what Smriti said, I think, see, the biggest point is, historically, since palliative care was started for malignancy, people still think it's for malignancy and those with advanced care, advanced stages of cancer. If you see the number of people affected by non-cancer in this country, there is much more than the 1 million new cancer that we add every year. And like Firoza mentioned, non-cancer lives for a longer period of time with poor symptom control, like a diabetic or a dementia or a COPD or an ILD. And when I diagnose a patient to have COPD, he doesn't realize it is life-limiting. I don't tell him it is life-limiting. As a pulmonologist, so as a training itself, we are not taught about conversations, honest conversations with patients. So people feel that the inhalers he's taking is going to cure him. He never realizes that it's a failing lung function, that he will need oxygen, that he will need NIV, and he's going to die of his COPD. So very often, it is also what we are taught in our training. It is also how doctors perceive this whole concept of who has the time to sit and listen to his full Ram Kahani. I have 50 more patients to see. So that is where the role of GPs and palliative care come, because you can actually give that support and time that the patient need, that busy hospital consultants can't. So it is to start with hospital consultants. It is to start also with patients, because nobody wants to die. Like I said, we are a death denying society. So if you tell patients that, look, this is not doing good, you are going to die, it is not received well. So how you tell the patients this is also very, very important. So the breaking bad news is an extremely important tool to learn in a communication skill. You tell the patient the truth and give him the realistic hope of support during the journey. Even though we cannot solve all his issues, the point that we are there for him in this difficult journey is what makes the difference. The third biggest barrier is in India is the family. Very often family says, patient ko mat batana, patient ko depression mein chala jayega. The collusion. Patient is already knowing what is happening in his body and is prepared to talk to you. But we don't tell him anything. Every day he goes to cancer hospital for radiation, but the family thinks he doesn't know about his cancer diagnosis. So the collusion affects, because if you tell the patient, he himself can tell you what he wants and how he should be treated, which reduces the guilt that family faces. Because now the family is guilty, saying, how can I let him die? How can I not admit him to hospital? How can I not feed him? How can I not do this? The whole point is, if he understands the information, then the approach is different. And for that, everybody needs time. So integrating palliative care early helps, and there's enough evidence to suggest that it not only improves the quality of life of the patient and the caregiver, but actually also improves to some extent the quantity, because patient is much more happier. He's spending time in doing what he enjoys before death rather than being in hospital surrounded by tubes and machines. So I think the barrier is at all levels of the society, and it starts with the medical profession, because in corporate hospitals, the dictum and the joke in palliative care circles is it's for the rich who cannot come out and the poor who cannot go in. The mentality and the revenue generated corporate hospitals is very different. And I appreciate that we need to make money, but I also think goodwill goes a long way. I also think now, in only with 5 years of experience, I have realized that people remember you for the good conversation you've had and for the dignity you gave their loved one, that they refer more patients. So the turnover of the hospital bed is what's going to make more money. And we need to focus on that to the administrators, that having 80-year-olds and 90-year-olds locking your bed for 1 month is not what is going to give you more revenue. It's important to regenerate and turn over your hospital beds faster to make more money. So actually palliative care works much better in health economics also, keeping the chronic illness away and keeping the acute illness in the hospital so that they can get better and go back and be part of a productive society.
I think, as you rightly pointed out, between the cultural difference between Vajpayee and Bush, I think it's also civilizational, probably at a certain level, that we need to change our thought process. Because I think I often find children will come and say, we don't want people to say that we didn't care for our dad.
Exactly.
So going to the hospital, taking them to the hospital is not caring. Caring is at home. Often, I think the concepts have to change. I also think that we need probably more palliative care education at the MBBS level, which is just not there.
Yeah.
Absolutely.
Which is what the 8Com module, you can check it out on the website. It's Attitude, Ethics and Communication Skills, the short form being AETCOM. And those modules are meant to instill these qualities in a young 18-year-old mind, so that by the time he becomes 22 and a GP with an MBBS degree, we can think of him to have some attitude of compassion and some empathy to deal with these patients.
But also the MBBS education system should have a whole session or whole subject on palliative care, because it's just given very little importance, and the more you teach and train, the more people take it in their stride.
Yeah, and I'm sure Smriti will also agree. In your MRCP, we have 2 stations, which is one is breaking bad news and 2 is history taking, where you're marked on how you talk to the patient. So the person in front of you is an actor, and you have a little chit when you enter the station where you say, this patient has advanced, say, multiple myeloma. You have to tell him this and you have to support him. I mean, basically talk to him about his diagnosis. The examiner sits behind you and he watches how the actor in front of you behaves. So the actor is told to cry, yell, scream, run away, whatever. And you are marked on how you are able to get that person back into the room in the 20 minutes allotted to you, talk to him, convince him, allay his anxiety, offer your support. And so it's a big test. And I think that is where is important to train our doctors, that we are not sitting on a high horse because we've become physicians. We need to get to the level of patients, because without patients, I'm sure we are nobody. So it's important to get that whole focus, that we really need to get into the sensitivity of what the patient is going through. And that is where empathy, and that's what empathy is.
I have a question here from a general practitioner, Dr. Hemanti Vitlani. She's asking, a person aged 73 years old who already has dementia, at some point talks okay, how can he make a living will or express his wish to children only they can decide?
So I think you need a neurology to decide the capacity of the patient. So the neurologist can tell you the decision, the competency and the capacity of the patient. And after that, if she is competent or not, You could ask her to write, but otherwise engage in an active discussion with the family members, because things will get worse and they will only get worse. So it is now or never. So I think we need to act now so that we have everything in place.
Yeah.
Anybody wants to add? Yeah.
Sometimes it is even if the option of making the living will becomes too cumbersome or too difficult to follow, having that discussion and recording it, writing it down, or having an audio or a video clip of that. It may be a discussion within the family. The doctor may or may not be a part of it. That is also fine. And sometimes we think about it in retrospect, where now the patient is already either delirious or unconscious, and we don't know whether they would want a ventilator or not. So at this point of time, what I do is I sit down with the family and I talk to them and I ask them, at any point of time in their life, did your loved one ever speak about what happens when they become sick and they need to go into the ICU or they need to be on a ventilator? Did they express any wishes about it? And sometimes the answer comes out, because sometimes it comes that this what this does is it shifts the onus, like it forces the family to take a step back and just reflect about their life with that loved one, what choices they have made, what thoughts they have had, what discussions they have had. And sometimes it must have just been a clear-cut statement at one point of time that I don't ever want to be on a ventilator, I don't ever want to do dialysis. And then that helps the family make a decision.
It could also be a very one-off statement like, I want to go walking, talking. I don't want to be a burden. I don't want to be bedridden. And very often when you're watching a movie or a serial, I don't want to suffer like this. And that's a big cue. It is very important, therefore, for family members to take this cue. And because, to be honest with you, if I take a poll now of all the GPs attending, I don't see anybody who stands in front of the altar and says, God, take me to ICU, keep me alive at all costs. I don't think there's any single human being. Yet our ICUs are full because we do not ask people their choices. If we asked people their choices and we document it, I am sure a lot of our senior citizens don't want to go that way. But we need to start talking. I think the biggest thing is the conversations, and it's very, very important to start there. More so in the pandemic. Sorry, Firoza.
Sorry, no. I also think in this particular case that the doctor who asked this question, if this patient still has lucid moments, don't lose time, because my mother had Alzheimer's for 12 years. I saw how she went down, but there were times in the early years when she talked very normally, she was able to express herself. That is the time when we need to get this thing recorded. So while your patient still has lucid moments, please quickly don't waste the time. It won't happen with Alzheimer's patients. It doesn't just happen overnight. It is.
I will also add one more thing, is also the unfinished business, because a lot of times financial issues create complete chaos and divides and breaks families. This is the time to sort those things out, so that even the human being is relieved that when he or she is alive, a lot of things have got sorted out, and hopefully the children, will all at least be cordial to each other, if not too much.
And in fact, even with my mother, she told me a couple of things which after she died, I told my sisters, no, she did say this to me and I have to honor this. So even though I hadn't recorded, they trusted me. I was the only daughter who lived in the same city as her, so I spent most time, I was the one who spent most time. But I did get down to asking her some of those questions, even when it was, at that early stage. Later on, she didn't know who I was. So she wasn't going to trust me and she wouldn't have known what she's saying. I also want to say something that, Rajan talked about earlier, and I think Smriti also, that doctors, you guys are very busy with your profession. You've got patients lined up. In palliative care, our first visit, we normally spend 2 to 3 hours. We spend so much time building up trust, building up rapport. We go into the history. We talk separately to family members. We talk together. We give that kind of time, and therefore that's the kind of communication that you need. We look at them straight in the face, we hold their hands, where we have that time which you don't have. So I think palliative care doctors, physicians and general physicians can work together. You've worked with this patient for many years. You've seen the trajectory of their various illnesses, their ups and downs. You know the family. We come in later, but we spend much more time. We must work together. I think that's very important. We're not giving enough attention to that, I feel. We're all compartmentalized. We shouldn't be compartmentalized.
Just to add to that, I find it very hard to discharge a patient from a hospital without him or her having a GP, because somebody has to continue what I have started at home, which is why we need GPs to be empowered with palliative care, so that that patient, we are happy to empower GP so that that patient is looked after the way he or she wants to. And the family is not stressed all the time. Oh God, what am I doing? Am I doing right? Am I doing wrong? Today's urine output, today's bed sore. It's a constant roller coaster for the patient and the family. So you people can be such a big support for the patient, family, and the hospital consultants, and a big bridge to take palliative care to people's homes.
Any more questions? Or I think we should.
Madam, we have the president of Bombay Seaward Medical Association as well as the GPA. I don't know whether Dr. Bharat Bhatt has left, but we look forward to having some kind of an active workshop with you and do further in this. I have had situations where, especially in a comparatively young patient, when the next of kin is afraid to take a decision of palliative care, thinking that what would the in-laws think of me, that I was not willing to spend for my wife or my husband, and I'm taking this decision. That aspect is also very important at times.
So that's where when Firoza says we have family meetings. So everybody's point of view is there on the card, including the doctor saying it is futile, it is torture, it is something not to be endured. And therefore, it is not easy. The family has a lot of dynamics. There's a lot of politics. And there's somebody holds the purse strings, somebody else holds the decision-making authority. And somebody else is a carer. I know it is difficult, but at least we need to try.
And the in-law should be also incorporated in that
Absolutely.
family.
Absolutely.
Inverted commas.
Absolutely.
That's where I think having family meetings, even repeated ones if needed, help. And that's where the palliative care team comes in, because, in a hospital, it's all about discussing with one relative and one relative only. One person is sort of the decision maker, but then that is not family dynamics, is it? So if we have these discussions at home or someplace where everybody is able to join in, it's fine if more people come in with their opinions. Let them also come in on the table. Let them also voice their opinions. And then we look at the pros and cons of it and reach a combined decision. Because even if we sort of nudge the caregivers or sort of force them to take a certain decision, the guilt that, oh, they did not listen to this or that person will remain. And so they will not be satisfied in the long term with what they have done.
And that's the one plus side of the pandemic, that we've actually managed to speak to the daughter from Melbourne, the son from the Los Angeles. Everybody is on the same Zoom call. Yeah. And that has helped. So I mean, that's something, because, now we don't have the excuse of not being able to be physically present. We insist to have that family meeting so everybody's on the same page. So that is the only plus point of the pandemic.
Dr. Advari, you had...
We'll call it a day.
Yes.
Yeah, sorry.
Dr. Advari, you said something about this. How can you help a CKD patient on hemodialysis in the chat?
Yeah.
One other barrier to palliative care is that most doctors follow procedures, doctors follow guidelines. Most guidelines do not incorporate palliative care. There are few guidelines that have started incorporating now. Oncology guidelines do. And now many renal guidelines, many kidney guidelines have started incorporating palliative care in a certain population of patients, those who are aged 75 or above, those who are frail, those who have multiple comorbidities. There is a frailty index that some of them check. The nephrologist has to offer a non-dialysis route option to these patients, a non-dialysis options while discussing treatment of their CKD. So this is something that nephrologists are now getting more and more information about. They are getting more and more aware, and my nephrology referrals are increasing because of this. So patients who who have CKD and who are not on dialysis, they form a good chunk of palliative care patients. Even the patients who are on CKD and on dialysis, they have symptoms which need relief. Sometimes if the nephrologist is not able to take care of them, the palliative care physician can. They have a lot of caregiver burden which needs a lot of support. So they need a large support system in that. And it's not just, even in those patients who are in the non-dialysis route, they need to continue their follow-up with the nephrologist while also following up with their palliative care physician.
Thank you.
I think I will come to an end today. As Mrs. Bilimoria pointed out, that modern medicine started sometime in the 17th century. I think the cake of modern medicine was put in the oven then. It got baked only in the last century. The icing was put later of palliative care. And hopefully the smart technology that COVID-19 has brought to us in use, of having patients use that to stay in touch with their relatives in an environment where they're completely isolated, shall be the candle on the cake. So which should throw some light. So we have some positives from this, and hopefully we'll learn better. Thank you all for a great presentation and a great
Thank
webinar.
you. Thank you all. Thank you very much.
Us.
Thank you.
Sarah, thank you.
Sarah has left already.
No,
Oh,
I'm
she's
here
there.
only, sir.
Hey,
I
she's
can't
there.
go.
Sarah
She's there.
can't leave. Can't leave. Thank you very much.
Okay.
Okay, I think